This is for the differential diagnosis of the gastrointestinal exam. We are going to be going through the 4 different techniques for differential diagnosis of a suspected area of pain in the abdomen. The techniques will be observation, inspection, palpation, auscultation, and percussion. So starting with observation and inspection, we have the patient with their knees bent up so that the abdominal area is relaxed. Therefore, it will be easier to visualize any muscle guarding they may be having. We can look for any suspicious moles in the area that may warrant them seeking medical attention of a dermatologist. Also, we can look at scarring from potentially past surgeries, as this patient has here, making sure we're aware of what that is from their past medical history. Also, looking down at the same angle, we can look for any symmetry issues. For example, in the balls, you may notice a distended area where there would be a dilated loop of bowel. We also notice the normal divoting in this area. If this was protruding out, that could be an indication of an enlarged liver for that area. Also, in thinner people, you can see right above the umbilicus where the abdominal or aorta may see some pulsations. So following the observation and inspection, we're going to do the auscultation. So starting in the quadrants, moving throughout all 4, starting in the right lower quadrant, we are just listening for some normal bowel sounds. Moving up to the right upper quadrant in the ascending colon, across the transverse colon, the splenic flexure, and the descending colon into that left lower quadrant. The bowel sounds are fairly easy to hear. They're going to be medium to high in pitch. You're going to want to wait about 20-30 seconds till you hear them, and their average is about 5 to 34 per minute. Moving on from the bowel sounds, we're going to listen for vascular sounds, checking for any abnormalities such as a bruise. This may be indicated with a patient who's come to you with syncope or complaining of falls or a history of cardiovascular disease. So starting at the abdominal aorta, what you're normally going to hear are continued bowel sounds or the heart valves closing. Moving to the renal artery, the left renal artery, and then the iliac arteries. Bruits, if heard, is due to the narrowing or an obstruction of that vessel due to atherosclerosis. If you did hear this, this would be an indication for you to send your patient for a medical referral for further follow-up if this has not already been diagnosed. Following the auscultation, we can then begin the percussion. So the percussion is where we're going to be performing tapping in the different quadrants, listening for changes in sounds to indicate any abnormalities. So percussion, we're going to start in one area looking for where that liver may be located. So in the midclavicular line, moving superiorly, we're going to be percussing. And here we can hear the tympanic sound, which is going to be normal in this area from the air and gas of the bowel. It's a hollow-like. And then here, right about there, you can hear where it becomes more dull in sound. So that would be the edge lower edge of the liver, and we can move up following that dull sound to right about there. It changes. So that would give us an indication of an approximate idea of the size of that liver. We can then measure that, and as long as that is 10 centimeters, that would indicate a normal size in that liver. We also could use a scratch test to give us an idea of the borders of the liver, where we're going to put stethoscope here and just gently performing a scratch. And you can hear again where that sound of that scratch changes, where the liver is brought more to the surface of the abdomen. Continuing the percussion, we can move to the left side where the spleen is going to be situated. Now, normally you can, when we move to palpation, palpate the liver. The spleen is a little bit harder to locate. So as I'm percussing, I'm going to have the patient breathe in and out, and that way I can assess if that spleen, the diaphragm will push it down and out towards the umbilicus. There would be a change in my sound of percussion from tympanic to dull, and that would be an indication of an enlarged spleen. So I'm going to ask the patient, can you breathe in and out? And we hear no change in that sound. So right away, that would give me an indication that right now I'm not worried about an enlarged spleen. So the last part of the exam would be the palpation. We save this till the end because we don't want to cause any distress to the bowels and artificially create any bowel sounds or peristalsis. So beginning with the palpation will be light palpation, where we're going to use the palm of our hand and just gently about 1 centimeter pressing down. This is to assess if there's any tenderness, so we'll be looking at the patient's face for any grimacing. We also can be feeling for any superficial small masses. Moving again through each quadrant of the abdominal area, watching for any tenderness or muscle guarding. We then move to the deep palpation using one hand, more just to feel, and the top hand to press down. The deep palpation, again, you're going to want to watch for grimacing in the patient and if this causes any pain.
A little discomfort.
A little bit.
Discomfort more than pain.
Okay. So with the deep palpation, we're feeling for any abnormal masses or enlarged organs. Again, making sure we perform this palpation throughout all 4 quadrants. Now, in terms of deep palpation of the liver and the spleen, we'll just be discussing this for differential screening, but for the liver, you can get a deep palpation of it by bringing one hand behind their flank area, lifting upwards to help move that. Oh, you can relax, I'm just lifting upwards. And then having the patient inhale and exhale, and as they breathe in, pressing down below that intercostal margin to feel for a ridge of an enlarged liver. You also can continue this onto the left side for the spleen. Again, lifting up in the flank area, pressing in below that intercostal margin as the patient breathes inhale, and as they exhale, pushing down further. And typically, you're not going to feel the spleen. If you do, that would be an indication again of an enlarged spleen. If either of those were positive, you would want to refer your patient back to their physician if they're unaware of that. Also, for the spleen, you can have the patient roll onto their right side. That way, it's moving the spleen with gravity down towards your hand, as again, your one hand's at the flank and then pressing down and in. Sometimes gives you a better feel for that spleen as gravity assists it moving down out towards the umbilicus. Further testing, if your patient is complaining of lower quadrant pain, in the right lower quadrant would be the appendix. If you're concerned of an appendicitis, you're going to want to do the McBurney's point, which is finding the patient's ASIS and the umbilicus halfway between there. And by pressing down, does that cause you any pain? No, so that would be a negative. If the patient said yes, and this would be pain, that would be a positive sign for an appendicitis, along with the cluster of signs and symptoms of going along with appendicitis, such as fever, chills, sweating, vomiting, etc. Other ways to assess for appendicitis would be the Rovsing sign, which is moving onto the left lower quadrant, pressing down, asking, does that cause you any pain? No, so that would be a negative. If it was a positive, it would cause them pain in the right lower quadrant as you push in the left, indicating appendicitis, as you're putting tension on the fascia and the peritoneum where there would be inflammation. Now, if you pressed for the Rovsing sign and you get pain in the left lower quadrant or bilaterally, that might indicate a different organ, such as maybe with an inflamed peritoneum or an enlarged bladder, causing that bilateral pain, or just on the left. Now, the rebound tenderness is another test you can use for an appendicitis. This one is typically you wait till the end to perform because it can cause quite a bit of pain in a patient, unless you're quite certain they are having appendicitis. Some clinicians will do the rebound tenderness right off the bat, so then they can get them out the door for an emergency removal of the appendix. So the rebound tenderness is, again, you're going on the left lower quadrant, pressing down. Does this cause any pain? And then quickly releasing. Does that cause any pain? Now, as I released, if that caused pain, that would be an indication that there could potentially even be a ruptured appendix, because as that ruptured, the inflammation would have spread from staying in that right lower quadrant into the left, as the peritoneum would be inflamed. That obviously would be emergency medical referral. Two other tests for an advanced exam of the abdomen, if your patient's having lower quadrant pain on the right or the left, would be the obturator test and the iliopsoas sign. So if your patient is having right lower quadrant pain, you're going to want to assess that iliopsoas or obturator are in that lower quadrant. And so if we're testing for the iliopsoas, I would have the patient extend your right leg out. And I want you just to hold it here. Don't let me push it down. And does that cause you any pain in your stomach? No. Go ahead and relax. So that would be a negative. If that was positive, that can be, again, if the appendix is inflamed, putting pressure on that iliopsoas in that area, or another organ that may be inflamed, again, with enteric inflammation as well. The obturator test, I'm just going to have you relax. I'm going to move your leg, and you're going to move the leg into an internal, external rotation. That way you're stretching the obturator, asking, does this cause any pain in your abdomen? No, so that would be a negative. Positive sign would indicate something is inflamed in that area, whether that's an appendix or another organ, indicating them to follow up with their physician for further assessment. Now, lastly, for deep palpation or assessment of the kidneys, we're going to have the patient sit up. I'm going to have you sit up towards me with your legs on the side. So go ahead and swing your legs down, and then go ahead and sit up. Yep. So for the kidney, lastly, the kidney is gonna, be lying in the mid-back area. You're gonna want to assess the right kidney, as this is easier for palpation or percussion. The left one is usually hidden behind the bowels. So go ahead and just sit up naturally. You're gonna place one hand over the area of the kidney, and then you would be percussing down through to notice any changes. Is it tympanic? You maybe would hear some resonance from the air-filled lungs, and then asking if that would cause any pain. Could be an indication of a kidney infection. So that completes our gastrointestinal differential diagnostics exam, looking at observation, inspection, auscultation, percussion, and palpation.